Hi, Dr. Martin. Welcome to the conference. Can you tell us what kind of doctor you are and where you're located?
Yeah, it's a pleasure to have this invitation, Darryl. I'm a radiation oncologist based in the city of Newcastle, which is just north of Sydney in Australia. But I'm actually originally from New Zealand. Done a lot of my training in Australia, but also did some of my advanced training in Toronto, Canada, and I've practiced as a clinician as well in Europe. So I've got a sort of a bit of the United Nations aspect to my practice as well.
Excellent. And that's always welcome. I mean, we get too conditioned here in the States to think that all doctors are from New York City, and better to know that there's a whole planet around us that takes care of people. So as a radiation oncologist, I mean, you're seeing prostate cancer patients. Can you talk us through some of the treatment opportunities that you offer them?
Yeah, for sure. And one of the really great mechanisms we've set up here with our urology colleagues is really a shared decision-making approach where at the time of diagnosis, most guys get a chance to meet myself or one of my colleagues to explore the wide range of options that often are appropriate for them to consider. As I'm sure many of your base will be aware, there's various ways of doing surgery, but there's also various ways of doing radiotherapy. And it's of interest that there's been a big clinical trial that came out of Britain a few years ago where they actually took a whole bunch of guys and randomized some of them to radiation and some of them to surgery. And really over 10 years, they had exactly the same cure rate. So we really locally, we sort of just tell guys, you can put that out of your mind as a consideration. It's really more about, what's it like to be on the receiving end of these different treatments? And with the radiotherapy, all it really is just generally very strong X-rays. So if you've had a chest X-ray or even a CT scan at some stage, it's actually the same physics, but we just dial up the energy so that we can actually kill off the cancer cells rather than just take pictures of them. And so external beam radiotherapy, which is the most common sort of radiation, that's the one where you really just come in, lie on a bench, have these X-rays focused on the prostate area. Often the treatments are over within a few minutes, all outpatient based. And guys usually get fairly minor toxicities, usually related to a little bit of bladder irritation or a little bit of a flow issue as they go through the treatment. That usually clears up within a few weeks afterwards. So we have guys who just carry on working. They're not radioactive, so they can still be around their family, including children. Really doesn't usually have a big impediment to their quality of life as they're going through this treatment. There's lots of different flavors of giving the radiotherapy, and I'm sure a lot of your men would have heard of things like CyberKnife and protons and other various approaches that are available. And really, none of them have really been shown to be any better or worse than the other. They're all just really different shades of the same recipe, really. One thing that has come through that's quite fundamental, though, is that we used to give radiotherapy in very small bite-sized chunks over many, many weeks. So there was these centres giving it over 8, 9 and a half weeks every day of the week, 5 times a week, which can obviously become a little bit onerous, particularly if you've got guys from regional areas who might have to do doing more travel on a day-to-day basis. The regimen's now getting more and more compressed. In Australia now, it's very common on the basis of research that we've been doing over the last decade or so to give the treatment over 4 weeks and just give a little bit more each day. But then there's a whole literature now kind of emerging where it may be for appropriate men that giving the treatment as few as 5 visits may well be a very reasonable approach. And for guys whose bladders are in reasonable shape and who are well informed, that's often an option that we roll out both as a standard of care as well as on some of our clinical trials locally. And I know in the US and North America, the use of these kind of 5-day regimens, which are often called stereotactic treatments, has really been taking off over the last few years. So, and then on top of that, we have brachytherapy, which is where the radiotherapy actually gets injected directly into the prostate in various ways. There's seed brachytherapy. There's also one's called high-dose rate brachytherapy. And to make it even more confusing, sometimes that can be sort of integrated with the external beam radiotherapy as well. So I guess one thing for you guys to probably take on board is there's a lot of moving pieces there's a lot of options. They're not all appropriate for everybody. So actually having a chance to discuss all this with a radiotherapy specialist with an interest in prostate cancer right at the time of diagnosis is often very appropriate. As a lot of you guys will be aware, you usually have got at least a few weeks to sort of absorb information, get appropriate opinions, take everything on board so you can make an informed decision. So we're very keen to be part of that conversation, because for a urologist to convey all of these different flavours and tailor it to the patient's situation may be challenging. And I think it sends a good message to patients, to men, that the medical colleagues are actually working well together, and that they have the patient's the patient really does get the deciding vote, because there are often multiple reasonable treatment options to look at as well.
So you've mentioned that the various flavors of radiation therapy essentially achieve the same quality of outcomes, and they're comparable to surgery. And within our support group network, which is now like 22 years old, I mean, we've heard about the idea that, we've seen papers 15 years ago doing a comparative analysis, surgery versus external beam radiation, IMRT, when it was first put on the scene. Basically, it's a crapshoot. You just toss a coin or whatever you choose. You should feel comfortable with. But it also the opportunities for so many different kinds of treatments confuses patients in this respect. If one thing works just as well as another, why did anyone try to develop yet another version? Why was proton therapy developed? Why, is there stereotactic? Why did we could understand the economy, both in time and cost, for reducing the fractionation of, going from 40 treatments to 5 for IMR, for external beam therapies. But if the outcomes at the end of the day are comparable, what were these inventors trying to achieve, trying to improve on? Which is another way to say what's wrong with the primary treatments.
Well, they're just all different, right? You might get to your holiday destination, but some routes might be a little bit bumpier than others, and it's really part of our job to help men really prioritise, in a way, what the deal makers and deal breakers are for them. And so, for instance, I get some guys that just intuitively the idea of surgery and the thing being removed out of their body just makes a lot of sense. Whereas the idea that everything sort of stays in there and you kind of treat it at a distance and don't actually ever lay a hand on a person, they just can't get their head around that, in which case surgery is the right option. There's other guys, for instance, that sexual function is a huge priority, the number one priority beyond being cured, for instance. And for them, what we find, if they've got intermediate risk disease, they're not going to need any hormone therapy or any other adjuvant sort of approaches, then the risks of erectile dysfunction following radiotherapy over the next few years is much lower than even with nerve-sparing radical prostatectomy. So it may be that something like that helps them advance their decision-making. So I guess sort of the short answer to what you're saying is that more options are always better than less options. And it then comes really down, I think, to the clinician to really sort of help declutter the in-tray based on the individual male preferences, really, about where their priorities kind of lie. And if when they sort of say one thing or another, then that often kind of gets things sort of off the agenda, and pretty quickly you can narrow it down to a fairly focused discussion.
With surgery, you sort of know where the prostate is. I mean, you're looking at it, whether it's robotic or open. You have, a knife, whether it's electronic or a kitchen knife or something, a more advanced form of that. But you can see the prostate, you know what you're removing, you know the landscape, surgeons know the landscape. And as you're cutting around, the landscape sort of reveals itself so you could alter course as best you can. With radiation therapy, though, you're not looking inside. I mean, or when you are, it's, a very good estimate. It's an image, but it's not as precise as my television set or my computer here. How do radiation oncologists understand where to radiate, where to not?
Yeah, so there's kind of two aspects to that. One of them is the imaging. The other one's the management of motion and uncertainty. And I guess the imaging we now are able to integrate into our radiotherapy processes are excellent. We're able to use high Tesla multiparametric MRIs, PSMA PET. So we're able to integrate all of that into our planning process, get a lot of peer review and other engagement from other clinicians. So we actually have a lot of quality control built into the process. And then as far as things like if the tumour moves around during treatment and stuff like that, we can make allowances for that in our planning process. And then even during treatment, we've moved beyond just using X-rays to sort of check where the prostate is or where the gold seeds within the prostate might be as it moves around. But cone beam CT, so we're often using three-dimensional imaging now to capture the position of the prostate. And even MR Linacs, which would actually have a fully functional MRI mounted into the radiotherapy machine, are now becoming reasonably widely available on the market. So we're able to do really high-end imaging and even do cine MRIs. So, 4D, see if anything's moving, as the bladder fills or the, a bit of bowel wind kind of goes through. So, yeah, we've got to, we fully acknowledge what you sort of say, and there's a huge number of steps we try to take to be as spot on the money as we can be.
Yeah, and you may not know, Malecare has a patent on a nuclear medicine quality assurance device that measures in real time how many gray units are going in and where they're coming out in the body as a way to sort of understand lifetime radiation loads and such. There are many men, and we're proud of that we're like this small nonprofit that does high-tech science, which is very cool for us, and good for patients because they benefit from it. But the idea of putting in a lot of radiation in the body, by the time a guy gets to be prostate cancer worthy, he's like 40s, 50s at least, usually 60s, 70s, which means in 2020, in his early years, including me, frankly, he's had rather comparatively primitive forms of X-rays, CT scans. I found in my parents' apartment this series of chest X-rays done on me when I was like my son's age, 8 or 9 years old. I mean, it's extraordinary. So we carry this lifetime of radiation prior to our prostate cancer therapies. Is there any reason to be concerned about that?
Yeah, well, I think any medical intervention, it's a balance of the risks and the benefits, isn't it? And the same conversation applies to surgery. I mean, there is risks from the anaesthetic and from bleeding and infection and you name it. So this is all part of the informed discussion. And, quite often now, not only do we have a discussion, but we try to write down the relevant points, print off relevant information, and particularly if a guy is eligible for a clinical trial, we can then give an exhaustive overview with a patient-informed consent form as well that can go into all of these things. But you're right, like for radiation, there's risks and benefits, and particularly for a younger man, if you were in your mid-40s and had treatment options, radiation probably does have a second malignancy risk as far as, like, say, causing a bladder cancer down the line or a rectal cancer. And even though that might only be a 1 or 2% risk, that's not a risk associated with the surgery. So, like in my discussions with younger men with a new diagnosis of prostate cancer, that's a relevant factor to take on board in the decision making, and often sort of tips the scales more in the surgical direction. So, I think it's a good point that you raised, that you've got to kind of look at the dark as well as the light side of every intervention.
Yeah, and it always returns us to the idea a really good consult is the first step towards good therapy and good treatment, and to engage a doctor who cares about you enough to consider all the possibilities and to perhaps refer you to someone who does something else. You mentioned PSMA and PET scans and such. There's this and you're correct. Imaging now is it's not even Web 2.0 or imaging 2.0. It's imaging 200.3 or whatever, compared to 5 or 10 years ago. What do you see? Your career's at least 5 minutes old. You've been practicing, for at least a decade or two or so. I mean, this must be an extraordinarily exciting time. What should a patient be excited about, imaging in 2021 and 20?
Yeah, so I think PSMA PET has really been terms like game changer probably get bantered around so often you get a bit jaded with it. But I think it really has been an extremely eye-opening innovation that's now really been integrated into standard care for prostate cancer management, at least in Australia, and I think fairly soon, really all around the world, because the PSMA PET, it's more accurate than the standard other approaches, including bone scans, CTs, MRs, all the other things you'd be familiar with. But it's also got less false positives, so you're not going to find other little gremlins that then need other sort of tests to be done to kind of reassure yourself that it's not an issue. It's actually more cost effective than doing all these other sorts of tests, and it's really got quite broad application. So we use it a lot for guys who have initially been diagnosed. And not everybody at the time of diagnosis needs any sort of scans. So if you've got a low Gleason score tumour, low PSA, your chance of having any spread is essentially zero. So really, standard care, I would argue, would be actually not to put people through extra scans at that sort of stage. But if you've got a high risk tumour where there is some chance of some spread, doing some form of imaging, and PSMA PET is something that we've done research on in Australia and done a randomised trial showing it's superior to the standard sort of conventional imaging. So we see that as really supplanting the old scans we used to do. But probably even more usefully, it's quite a broad application type technology. So, for instance, for guys who've, say, had surgery and the cancer's come back in the form of the PSA blood test rising, standard care for us now would be to do a PSMA PET from a level of a PSA of 0.2, and that aligns with the European Urological Association guidelines. And really, if we're able to, and even at that level, we often can find little specks of the cancer in a lymph node or something. And then obviously that's very helpful for us instead of just blindly trying to cast a wide net with any salvage radiotherapy. We're able to be a lot more sort of tailored in how we direct our treatment. And just while we're on PSMA, it goes right through the spectrum of disease. Like some research done in Australia looked at guys who've very, very widespread disease, really getting into the final sort of lines of chemotherapy, and compared PSMA PET lutetium. So this is this area of theranostics where you can actually take the PSMA molecule and hook onto a little radioactive emitter. And so as the PSMA lands on the cancer, it's then able to kind of get locally irradiated. And that study actually showed, compared to cabazitaxel, one of the other chemotherapy agents, that the chance that there was a survival advantage, and that was presented at ASCO, the big sort of cancer meeting a few months ago, and the manuscript's under preparation now. So PSMA, it's not just a niche thing; it's something that really is relevant right throughout the prostate cancer journey for a lot of men now. So I found that to be a really exciting thing to be involved with, as it's gone from really 5 years ago being invented, to now being pretty much standard care.
Yeah, and it's exciting for us too. I mean, it took us 15 years to understand anything, and to see this evolve over the last 5 or 6 years is quite something. Actually, if you wouldn't mind doing just like in 90 seconds or less, clearing up confusion or putting an end to whoever's confused watching this, PSA versus PSMA. What's the difference? 90 seconds or less. Go ahead.
I'm going to tell you in 30 seconds. So the PSA is the prostate-specific antigen, which is obviously just a protein that gets squirted out from your glandular cells in your prostate, as well as from prostate cancer. So it's a serum protein that we are able to measure very accurately. PSMA, the PS and A all stand for the same thing, but the M stands for membrane. So prostate-specific membrane antigen, which confusingly has absolutely nothing to do with PSA. It's a receptor that sits on the surface of the cells, and it really is a very reliable signpost, really, to what is a prostate cancer cell versus what it isn't, because the PSMA, although there are other tumours and body tissues that can have it, it's by far more common and focused and intense on prostate cancer than pretty much anything else. So it probably doesn't clear it up hugely, except to sort of say one letter makes a universe of difference.
Yeah, probably in billing as well. So with these, what do you see as like missing? I mean, if you could just invent something after we stop our recording and tell me about it tomorrow, what would it be?
Well, I think probably the most helpful thing isn't, as you say, there's actually lots and lots of treatments out there, and really because I guess we haven't even touched on all the chemotherapy agents and the enzolutamides and the darolutamide and all those other things as well. And really something that we found as clinicians, it's about integrating all these agents together sensibly, because if you just throw everything at everybody, it's, the toxicities add up, the expense adds up, and the benefits might be relatively modest. So really what we really need to do is get urologists, radiation oncologists, nuclear medicine physicians, medical oncologists, all actually coordinating and being involved with a man's care from the get-go. But even more critically, having clinical trials available to men to really help, make it just not a crapshoot. That you actually are scientifically just trying to understand what's the best glove to put on that particular hand. So it's a bit of a sort of a wacky answer to your question. Like I don't think we need more silver bullets. We've got plenty of arrows in our quiver. We just got to figure out which targets and how many to fire at the right time. And the only way we're going to do that is by having a team-based care approach, grounded in research, rather than maybe a model of the single clinician sort of calling all the shots for every patient, which was the traditional medical model. But I think a lot of centres are now beginning to progress beyond that. And I think that's a good thing.
No, totally a good thing. Unfortunately, there are many lesser developed countries and regions where they unfortunately only have one doctor, and there are entire portions of continents that don't even have a working linear accelerator or vault even. So treatment is in fact specific to developed countries, and we're trying to sort of defeat that kind of notion. The idea, though, that are you suggesting now that, as we close out 2020, imaging has gotten to a point where we could see what's harmful and target it with something?
Things like biopsies are still, necessary, partly because we're now able to do genomic profiling of a lot of tumours and get a better understanding of how they'll behave, as well as how they might respond to other treatments as well. So getting some tissue out of the tumour is still critical. But, it's never a bad thing to know as much as possible you can about a potentially adverse character in your life. So it's very common for people with more advanced disease to end up with a high quality multiparametric MRI interpreted by an expert in interpreting these things, as well as a PSMA PET, as well as tissue, as well as often genomic analyses. And sometimes we end up getting familial counselling as well if the family history is strong. So the imaging is a big part of the puzzle, but there's often a whole bunch of other ancillary parts. And something I'm really keen to sort of touch on as well is the survivorship aspect of things. And I know this is something that your group would have a lot of invested interest in, and probably one of my pet interests in there is exercise medicine.
Yeah. Let's hold that for just 5 minutes, though, because I'm totally enamored of the approach you're suggesting, and it's that we now have these baskets of innovation, these baskets of ways to understand things, and some of these methods look at specific parts of the puzzle, as you point out, and some have a bit more of a global view or a holistic view. And so we've reached a point perhaps where, and I want your opinion on this, so let me just throw it out. The idea that innovation is certainly important and we should continue. But we've gotten to a point where it's not the critical thing. I mean, it's not like if only we had a way to do X, Y, or Z. We now have so many things. It's about understanding them and integrating all the pieces of not the puzzle, but all the answers that we have and putting them together in some cohesive way that enables us to point out, create a direction for a patient's therapy in a precise way, a precision medicine sort of way. Well, what do you think of that?
Yeah, I think that goes back to your previous point about when you've got all these different options, why do you need more options? And as you say, often it can end up adding more heat without much light to the management of the disease. So that's why I guess I sort of touch on using clinical research as a critical validation step. So it doesn't just become in a way a marketing exercise of another another option without proof that it actually does add to the overall management of the condition. And by adding to the management, it's not just looking at what might be a relatively modest improvement in disease control, but also at what cost as far as increased toxicity, what sort of hit on the quality of life, what sort of financial hardship might be associated with it. So I think we really need to be quite energetic in making sure that when we develop something that locks it into that pathway, just seeing how it integrates appropriately into the landscape rather than just maybe putting up the website and the law of the jungle prevailing.
Very good. Before we get into the exercise and weight, resistance training, yes, I mean, now we're almost giving away the answer to the last chapter of our discussion, but you know a lot about oligometastatic cancer and how, radiological therapies may be beneficial and such. Can you talk a bit about that?
Yeah. I guess this is slightly coupled to the PSMA PET story as well, and that often after people have relapsed after surgery in particular, we'll find some lesions. It used to be that we would just, if the PSA was rising after surgery, we would just irradiate the area around where the prostate used to be. What we've now found is that in more than half of men, the disease is actually somewhere else. It's usually in a lymph node somewhere in the pelvis, and sometimes it's more further afield, even in a bone, for instance. And so what we've really looked at is, first off, using the PSMA as a way of kind of focusing our attention appropriately. And then really having a bit of a discussion, because we can often treat these lesions. So we've got the stereotactic radiation that a lot of you guys may be familiar with treating the prostate in only a few visits. We can use a similar sort of very highly focused approach to burn off lesions kind of almost anywhere, like in a rib, in a spine, in a lymph node, you name it. Often in as few as a single visit, sometimes 2 or 3 visits, give a very high focused dose of radiation. And that may actually be an avenue where you can sort of retard wider disease progression for longer than just planting somebody on hormone therapy or taking other sort of more conservative sort of approaches. So that's another option, this whole oligometastatic state. So we used to sort of thought once it's spread, it's a black or white binary sort of thing. But now the oligometastatic state, where you might only have 1 or 2 or 3 lesions, appears to have much more favourable outcomes with these kind of more focused treatments than the polymetastatic setting where it's sort of more widespread, in which case you're probably better off going down the avenue not just of hormone therapy, but possibly adding in chemotherapy and or enzalutamide and other things as well to try to really cast a whole body wide net against the disease. But yeah, there is this strategy now where you can sort of almost, they call it the whack-a-mole strategy, where you sort of do a PSMA PET, find a lesion, burn it off, maybe another one crops up in another year or two, and you sort of rinse, wash, and repeat that over several years. And then if and when it does become polymetastatic, that's when you switch gears into sort of the whole body sort of approach. So this is something that's quite exciting, but it's sort of also, it has to be tempered, because a PSMA PET doesn't see every cancer cell in the body. You've got to have something that's around about between 4 and 7 millimeters in size to spot it. And to get to that sort of size, you're talking about millions of cancer cells in one spot. So you've also got to kind of take on board, how fast is the disease progressing, how quickly the PSA is rising, how high the PSA is, what sort of grade it was at the get-go. Take all these other factors into account before maybe embarking on this on this kind of pathway. But once again, it's never a bad idea to have more options rather than less options. But as you might imagine, it's something that's quite a complex sort of treatment regimen to be kind of looking at, or management approach. Once again, clinical trials are always great if they're available, to get involved with them to really sort of learn something about who benefits, because not everybody's going to benefit from these sorts of approaches. So you want to kind of hopefully tease out who it's best to kind of invest their effort in going down these sort of routes. But I guess also appreciating not everybody has access to everything, but if you can get access to a radiation oncologist with a special interest in genitourinary cancers, they're more likely to be kind of across all of these various moving pieces and be able to help navigate through the various options.
Yeah. And, access to the machines is one thing, but access to knowledge and to people like yourself is becoming more and more widespread. I mean, what we're doing now is available to 8 billion people, whose only barrier is internet access, which is a significant barrier, of course, but the opportunity to expand knowledge and opportunities for information seeking has grown dramatically in the last 5 years, just as treatment opportunities and imaging has. As you treat people in advanced stage and oligometastatic and polymetastatic stages, you also see the impact of chemotherapies and androgen deprivation therapies on their bodies. I know you're interested in how to mitigate some of those toxicities through exercise. Can you talk a bit about that?
Yeah. I mean, the whole survivorship thing's so critical, and it's been a real shame to our craft that we haven't prioritized this as much as we should. Curing the cancer is obviously or controlling the cancer is often a priority, but you really want to focus on making it a life worth living as well. And particularly with the androgen deprivation, if you're going to be on it for a while, there's all these insidious side effects, which I'm sure a lot of your membership would be aware of. And I guess a whole bunch of them actually can be managed really well with exercise. So things like the increased fat, the reduced skeletal muscle, the thinning of the bones, the osteopenia, osteoporosis, your dyslipidemia, so your cholesterol might go high, your high blood pressure. So there's a whole raft of these things that has been proven that exercise will stop them. And in fact, the guys that we put on exercise programs, they have all their baseline sort of stuff done. And then after 12 weeks, the guys that don't have exercise, they all deteriorate. The guys that have had exercise actually end up better than when they started, even though they've been on androgen deprivation in the meantime, which is often seen as something that should slam the car into reverse, but actually often we get them moving forward. And then there's all those sort of soft benefits. They're often becoming socially engaged, because there's often a group aspect to many of these exercise things, and there's a lot of value in that for guys going through a fairly tumultuous period in their lives. And there's even research suggesting that the exercise can activate the immune system in various ways, which may even improve the cancer control outcomes as well. So it's one of those things. There's almost like no downside to it, because it just helps in every base regarding the prostate cancer, but it's obviously also helps as far as your heart health and everything else as well. If your blood sugars are off, it's just and it's free, really, or almost free compared to a lot of the other interventions we look at. So I spend a lot of my consults talking about this kind of stuff, as well as sexual health and all the other aspects as well. But the exercise stuff is something that's now really become standard to integrate early on for our men. And they're often a bit surprised that we can end up spending a lot of the consult talking about lifestyle and how to maximize their quality of life. But they get it. They sort of know that that getting on top of the cancer is only half the battle. It's really about sort of making sure that the life that's achieved from doing that is maximized. And and I guess just one point about the exercise side of things is a lot of guys think, they say, yeah, sure, I exercise, I go and pick up the mail, or take the dog for a walk or whatever. And I can see you smiling, because the whole exercise thing, it's a science, right? I'm not sure what they're called in North America, but we have exercise physiologists here. They're graduate trained. They know all the different types of exercise. They talk about an exercise medicine prescription, where they actually will select out the aerobic or the resistance or the loading or whatever to suit not just the where the man is, but where they need to get to, and even about doing low impact sort of stuff. So for the guy who comes in and says, "Oh, my knees are shot. I can't do anything." There's workarounds. That's it doesn't mean it's not a get out of jail free thing. But it's something we find it really important to engage that kind of expertise and tailor the exercise integration very well early on, rather than just the guy saying, "I do a few squats, and limber up in the morning, then I'm good to go." No, we need to do this structured, and we need to do this well to get the most bang for your buck.
Yeah, and how many people are even doing squats? I'm not. but you're. I mean. What within our social work world, our psycho-oncology support group world, we try to get men to think that you're not just going to doctors to increase your lifespan. We use this pithy phrase that I wish we came up with, we didn't, but you're going to increase your health span, and health is in fact about feeling good. For example, our mission statement, all nonprofits and NGOs have something, one-liner kind of thing to describe what you do. So, but ours, I think we take quite seriously. Malecare helps men live longer and happier lives, and there isn't much as social workers and psychologists that we could do to, make them do longer lives, except enhance the ability for them to have good consults with their doctors and make, well-informed choices, but choices they're genuinely comfortable with relative to who they think they are and who they are. But happier is something we absolutely can. And exercise, movement. You mentioned, it's funny to say I exercise by going to the mailbox and opening the mail. But there are, in fact, men who don't even leave aside from pre-COVID, there were men who don't leave their homes. There are people who genuinely are devastated by their diagnosis, even those who live with multiple people in their home, like family members or friends and relatives or whatever. The idea of any kind of activity, anything that sort of lifts the butt off of support, out of the chair or couch. These are great things, and we also say that prostate cancer diagnosis isn't going to kill you tomorrow morning, but it is a kick in the ass to think about your whole life, and, the classic Mediterranean diet is something, an easy suggestion. Movement is a much more difficult one because certainly like a squat. I find those not very appetizing. I used to do many people used to do them, but as we've aged into...
We all used to be awesome, right?
Man.
And the older I get, the more awesome I used to be. but yeah, I guess one kind of scary stat, I don't know if this is apocryphal, but I've heard there's suburbs, out some of the exurbs of the US where people are so conditioned to driving and, Uber Eats and all that kind of stuff. But the average step count at the end of a day can only be like 400 or something. There's not a lot of movement happening in the community. And so there's some really bad and toxic habits. And this obviously flows onto the obesity epidemic and a lot of the morbidity associated with and mortality associated with that. But they call it kind of the teachable moment, and as you say, the kick in the butt. You got somebody who's kind of receptive to listen about engaging in their healthcare. And so in a way, we can use that as clinicians as an opportunity really to be able to kind of progress something like exercise or healthy diet or whatever else that's actually probably going to make a bigger impact for these guys over the next couple of years than anything we're going to do from the prostate cancer point of view, particularly if it's one of these screen-detected early prostate cancers, which often take 10 years or more to ever cause any problems if they're not managed appropriately. So we, as you say, guys are often at that receptive moment, and I think as clinicians, we have a lot of authority to be able to activate them.
Yeah. No, well done. We've we're damn close to running out of time here. I mean, and so much to touch on. And I did want to talk about your travels and your work in other countries and such. One very quick thing that seems almost tangential to what we've been talking about, but is a bit of a theme in our conference, particularly because of in the States here, Black Lives Matter is a big thing, and I think around the world. Can you talk a bit? I mean, you're from New Zealand, you work in Australia, can you and have worked in and studied in Canada? Can you talk about disparity issues for prostate cancer among Indigenous people versus settler people or white people?
Yeah, I can touch on that because it's, as I guess you're fully aware, it kind of falls into the socioeconomic disadvantage, and that people who are just, not got good access to healthcare get worse outcomes. They present with more advanced disease. They don't get the opportunity to tap into standard care type interventions and treatments, and this whole kind of almost fantasy package of care that we've been talking about is essentially becomes inaccessible. And so really, and as you might imagine, health inequality, like income inequality in a lot of countries is growing, not shrinking. And I guess with you in an election season at the moment, this is something that's kind of front and center in the discussion about whether things are getting better or worse on that regard. And there's no easy fix, but I think there is at least an awareness from certainly from my peers that we've got to kind of make ourselves reachable. So in Australia, I think this happens to some extent in the US as well, there's been a real decentralization of radiotherapy. Like, it used to be something that was only available in major metropolitan areas. And if it was available in a regional area, it would be a bit of a, shall we say, a rump organisation. It wouldn't really be well integrated with state-of-the-art type approaches. Whereas I think we've now realised we've now got, in pretty much any city in Australia with more than around about 40 or 50,000 people will have its own radiotherapy centre, and it's just about always going to be integrated with some major network in some way as well, to make sure that it's that you're tapping into the kind of the world brain and not necessarily just getting maybe the second-rate sort of approach. So I think that's part of it, is increasing access, but also making sure the access is quality, and that's and I guess access in the US, the financial sort of side of it is obviously a huge player in it. And I know in the US you think socialized medicine is the work of Stalin, but certainly in Australia, universal healthcare has been it just removes all that stress about not being able to afford the care that you need to manage your health.
Well, before half of our virtual audience starts attacking the other half here, let me thank you for this wonderful conversation. Thank you for the care you've offered to your patients and to your community, and for your good work. And thank you for being part of our conference.
It was a pleasure, Darryl. Thanks for having me on board. I hope you have a great conference. Bye for now. Okay.